चालू करो.
Good evening, everyone. I am Faraz, today's moderator for the Clarinet. Clarinet is a part of this session as a digital partner. Clarinet is India's largest live digital CME and doctor-generated learning platform. With all of you, I am presenting a short video on Clarinet. Thank you so much all doctors for watching the video, and you all requested to visit our website www.clarinet.com, where you can watch lots of live sessions conducted by expert doctors across the globe. And we have mid-wiki service, which is medical Wikipedia for doctors only that you can read. Now I would like to hand over the session to Dr. Shubhadana Jattar ma'am, President of Menopause Society, Pune. Over to you, ma'am.
Thank you, Faraz. Welcome you all for this presidential webinar series in association with Pune Menopause Society. I welcome our guests of honor today, Dr. Neelam Agarwal and Dr. Meeta, and Dr. Shobhana and Dr. Anju Soni, Secretary General of IMS. I also welcome our speakers.
No, Dr. Seema also I will mention a special welcome.
Dr.
She's the
Seema,
Vice President of IMS.
Yeah, Dr. Seema, who is Vice President of IMS. And I also welcome Dr. Jyoti and Dr. Girija, who are our own people, and Dr. Jyoti and Dr. Parag are I think my mentors, and because of them I am in this IMS family. I am here today. I also welcome Dr. Jyoti Chandran from Calicut. Has she joined?
She has not joined. She will only answer the first question and she will leave, she said. Okay. She has a wedding.
And all our own panelists, my friends, Dr. Mahek, Dr. Kiran, have they joined? I don't see them. And Dr. Vaishali, and I think we have very interesting session today. Very less discussed topics like anticoagulants, which we use very routinely and we come across the patients, but it's not really discussed in detail much. So we have Dr. Jyoti speaking on surgery on patients with anticoagulants, and Dr. Girija speaking on control in patients on anticoagulants, and of course panel by Dr. Shobhana, estrogen and progesterone so routinely that sometimes so Dr. Shobhana has been conducting this webinar and I have attended few of them. She has covered each and every topic related to menopause in such a minute detail that if we attend those webinars, I think we don't need to refer any textbook or anything. It is so much in detail. But if you can put it on YouTube, it will be really beneficial for everyone.
Yeah, we are planning to, but Jyotika is out of station. I think she was not picking the phone. We are planning to do it.
I also welcome all the delegates who joined in, and I request Tanushree to introduce her as guest of honor, and we'll proceed with the session without wasting much time. Thank you everyone for joining.
A very good evening to everyone. We have two guests of honor for today's webinar. First is Dr. Neelam Agarwal. She's Professor of OBGY Department, PGIMR, Chandigarh. She was past President, Indian Menopause Society. She's a Chief Editor of Journal of Midlife Health. She has keen interest in high-risk pregnancy, perinatal health, and menopause. I request Dr. Neelam Agarwal ma'am to please say a few words.
Yeah. Thank you, Tanushri. First of all, my thanks to Dr. Shubda for giving me this honor. And I congratulate Pune Society for choosing such a beautiful topic for today's webinar, which is day to day in every OPD, every gynecologist faces these problems of AUB and then AUB on anticoagulants. This is a very, very uncommonly discussed topic. Although even though the AUB on anticoagulants is a very common complication of anticoagulation therapy, but usually it is under recognized, as usually this is a chronic complication. That's why people usually do not discuss it so openly. So this today's webinar, I think, will help most of the gynecologists who are practicing gynecology. And the anticlimax is that anticoagulation therapy, sometimes the medical treatment of AUB in the form of hormones, estrogens, especially estrogen, progesterone, or in combination, those are usually contraindicated in these patients for their medical condition for which anticoagulation has been started. So the trick is to weigh balance between thrombosis and anticoagulation complication of hemorrhage, and accordingly titrate accordingly. In each case, it has to be titrated. So we have very good speakers, rather stalwarts of IMS, and otherwise also very eminent speakers for today, and panelists and the moderators. So I welcome you all, and thank you very much once again, Pune Menopause Society, for giving me this honor. And I wish you all the best for your endeavor. Thank you.
Thank you, ma'am. Our next guest of honor is Dr. Meeta Singh. She was past president, Indian Menopause Society. She was past editor for the Journal of Midlife Health. And she was the one who designed the Indian guidelines for menopause management. I request Dr. Meeta ma'am to say a few words.
A very good evening, everyone. Thank you very much for the introduction. And so I'd like to congratulate and thank Subhada and the central team, Shobana, and the team who's here, Parag, for coming out with this. So there's always a huge overlap between, the hardcore general gynecology and the focused group of menopause. And I think today's topics, both the topics like Neelam has said, and I think Subhada also said, have been untouched in our IMS deliberations. So this is something new, and we look forward to listen to it from, the stalwarts. Jyoti from the menopause, and of course, Jyoti is not only menopause, as obstetrics as well, and RCOG. So a right person to deliberate on a general topic like that. And also look forward to Dr. Girija, who's, I've heard a number of times, and her academic interest and her master on these subjects is great. And I would really love to listen to what she would do if there is AUB and the patient is on anticoagulants. And Jyoti, I must say this topic really interested me because I underwent surgery, and I knew in these corporate hospitals, there is such a fragmented care that, the estrogen therapy, the anticoagulant, the anesthetist and the intensivist or the surgeons, they have no, coordination about what to do with this particular patient if she's on a hormone therapy or if she's on anticoagulant. So I think it would have been great. Here I see all of us are gynecologists, but it would be great if we had these other specialties in. I think we need more education on this topic to properly manage. So go ahead. I think, thank you so much.
We will start with LKG, then we'll go to UKG and call everybody else.
Thank you.
Seema, Dr. Seema, would you like to say just one words? And Dr. Ambuja, past president, I see them, both of them here. Just quickly.
Yeah, yeah. I also congratulate you all to selecting this specific
She's from
topic.
Jaipur.
Yeah. So,
Okay,
because
yes.
this is a topic which is a little bit unique and not discussed day to day, and it's very important also. So I really appreciated that you have picked up this topic for today's discussion. And
Do you teach it in
we
your
have seen-
medical college?
yeah, we have seen so many cases of DVT, particularly in this age group. And many times
Do
what
you
happens,
teach in
patient,
your medical college? You are a
yeah,
teacher.
yeah,
Do
yeah,
you
yeah,
do?
definitely.
Okay.
Definitely. Even we had a clinical case report seminar. We have a pathological seminar every Friday. So in that, I presented a series of 5 cases in which we took a woman in every age group of life.
Wow.
So we had a patient with infertility who
No, I'm
underwent
saying
the hormonal treatment.
anticoagulant.
And then she developed DVT and we kept her
Okay.
on
Very good.
anticoagulants.
Very
Then
good.
postpartum DVT,
Okay.
and then in perimenopause period DVT. So ultimately, when we see such type of
When we
patient
come
and
to
we
the
make
panel
history,
discussion,
we
I hope
come to
you
know.
will share with us all your cases. I hope you stayed
Definitely.
on till the panel discussion. In the end, I hope all of you give your inputs. Over to you,
Definitely.
Shubhada.
Pardon? Dr.
Over to you, Pune.
Is our chairperson now, and he'll
Yes.
start the lectures. Yeah.
Yes, we start with today's talks. I request Dr. Parag sir to chair the session. Dr. Parag Biniwale is a consultant OBGYN Pune, PG teacher and unit head of Kamala Nehru Hospital. He is president
That's
of Pune
okay. That's
OBGYN
okay.
Society.
Yeah, thank you. Don't waste your time in that.
Okay.
Right?
Thank you, sir.
All
I
right.
request you to start the session.
Sure.
Yeah.
Thank you. Good evening, all. And on behalf of Menopause Society Pune, I welcome all the office bearers of the Indian Menopause Society. Pleasure to have Dr. Shobna, Dr. Anju, Dr. Seema, and of course, our past presidents, Dr. Neelam, Dr. Ambuja, and Dr. Meeta to Pune virtually. Today, we are going to have different lectures all together. And when Shobna gave us those lectures, Shubhada and I did a lot of brainstorming, and then the first name that came to our mind was Dr. Jyoti Unni. Whatever difficult the topic may be, the one person who can deal with it is Dr. Jyoti Unni. Jyoti has been a mentor to all of us in Menopause Society Pune. Currently, she is the director of Department of OBGYN at Jahangir Hospital Pune, and a past president of Indian Menopause Society. And of course, for us, she's the backbone of Menopause Society Pune, who keeps motivating us. Jyoti, may I request you to start your lecture, Surgery in Patients with on Anticoagulants.
Thank you, Parag. And thank you, Shobna. I don't know whether to thank you or to
Or
see whether
I
I'm
don't
your
curse me, but I
enemy
really
or
want to
your
learn
friend.
from you.
But
It's a difficult topic, but I want to learn.
Yeah, I've had to do a bit of study this time.
Thank
So
you,
I guess
Jyoti,
that's
for
good
what you have done.
because it's good to study on some new topics, I guess, once in a while. So now the management of patients who have to undergo surgery when they are on anticoagulants is challenging because we have to most often interrupt the anticoagulation, and this increases the risk of thromboembolism. And if we continue it, it increases the risk of bleeding during surgery. So both these things would increase the morbidity and mortality. And so we have to achieve a balance, and we have to do it based on evidence and guidelines. So the types of anticoagulants that patients are on, whom we see and we still need to operate on, are the traditional vitamin K antagonists like warfarin, then the heparins, which are unfractionated and LMWH. And of course, with the low molecular weight heparin, it's not such a big issue. With the direct thrombin inhibitors, which are called direct oral anticoagulants or novel oral anticoagulants like dabigatran, rivaroxaban. And then more commonly, patients are on antiplatelet agents. So these are all the issues which I'll tackle briefly. So first we need to estimate the thrombotic risk and accordingly then decide how long we can stop the drug. So in high risk women, we have to minimize the interval without the drug. So in women who have had a transient increase in risk, such as a stroke or a DVT, if it is possible to delay the surgery by 3 months, then that would be the best option. If it is something where we cannot delay, then the risk has to be explained to the woman, and then we have to think in terms of what to do. But otherwise, if it's an elective surgery, it's best in such women to delay the the elective surgery. Depending on which anticoagulant we are using, we have to decide when to stop and when to restart the anticoagulant. And we have to decide whether bridging is required. That means to stop the oral anticoagulant and then give a short-acting agent such as heparin, and then when to restart the oral anticoagulant. In women with prosthetic heart valves or a recent VT or stroke or atrial fibrillation, we may need to do to continue and minimize the interval, because these are things where if a clot occurs, then the woman is likely to lose her life. On the other hand, we have to estimate the procedural risk and see how much of hemorrhage will happen. If it is a high bleeding risk, then we need a longer period of interruption, because we have to use the heparin for that period, because we'll have to stop the oral anticoagulant for longer. So if there are minor surgeries and we don't need to stop, if we are not using regional anesthesia, we'll come to regional anesthesia later, but small procedures, we do not need to stop. Though there are many anesthetists who ask us to stop even antiplatelets for minor surgeries, the guidelines actually do not recommend that we have to stop for either dental procedures or minor surgeries like DNCs. But if there are high-risk procedures, like, for example, any cardiac procedure, an intracranial procedure, any procedure on the spine, oncosurgery, renal surgeries, or any surgery which is likely to last more than 45 minutes, these are deemed to have a high risk of hemorrhage. And in these women, we need to stop the anticoagulant and we need to consider bridging therapy. If the woman has comorbidities such as deranged liver and kidney function, again, we will need to stop the surgery, stop the anticoagulant, and we also have to consider when to restart, because with deranged functions, then there can be problems with coagulation factors. Now, warfarin, though it is such an old anticoagulant, many women, particularly those who have prosthetic heart valves, are still on warfarin because it is an inexpensive agent and it has been used and time tested for so long. So, but it has a very long half-life, and so we have to discontinue the warfarin 5 days in advance. That is, the last dose should be on surgery day -6. And it takes that long to normalize the INR, and that is why we have to stop this much earlier than we do with other agents. On the day prior to surgery, it is prudent to do an INR, and if it is more than 1.5, it's better to give her vitamin K. The bridging agent, which is usually low molecular weight heparin, should be started at least 3 days prior to surgery, so that you have enough of the anticoagulant during the, for just before the surgery, so that the valve doesn't get clotted. Like I said, most of these are patients who are on prosthetic heart valves or who have had a stroke or a DVT earlier and are not on any of the newer agents. We can restart the warfarin 12 to 24 hours after surgery, because it takes another 4 or 5 days for the INR to build up to the levels that we need. And check the INR 5 days after commencing the warfarin, recommencing the warfarin, and then decide when to stop the LMWH. Now, as far as the direct oral anticoagulants, I've only talked about dabigatran and rivaroxaban here. It's quite similar with the other agents, but most patients are on one of these. Nowadays, I think the one which is fashionable now is the rivaroxaban, so most patients are on that. Now, in low or moderate risk of coagulation, you should omit of bleeding, of coagulation, omit it 24 hours prior to the surgery and restart it 24 hours after. Whereas if there's high risk of bleeding, then you need to stop it 48 hours prior and restart it after 24 hours. So bridging is usually not required with these agents because the effect lasts for that 24 to 48 hours. So you really do not need to wait for to start a bridging agent. Now, what about the antiplatelet agents? This is what I think is something which almost every one of our patients over the age of 40 is on one of these agents. So if she is just on ecosprin, if it's there just for prophylaxis, because she has hypertension or because she has had a coronary event earlier, then you can stop the ecosprin 3 days prior to surgery and start it 24 hours after surgery. However, if there is a stent in place, if there is a coronary stent in place, then the ecosprin should not be stopped. So this is something which we have to keep in mind, because the chances of having a myocardial infarction if we stop the ecosprin or the clopidogrel is much higher, and then that could lead to mortality. So either ecosprin or clopidogrel, if the coronary stent is in place and it is for this reason that they have been started on the antiplatelet, we should not stop it. And we have to take whatever precautions we can in terms of the bleeding to reduce the hemorrhage risk, and also keep enough blood and blood products ready in case we need them. With clopidogrel, because the half-life is longer, we have to stop it 5 days prior to surgery, but we can restart it 24 hours after surgery. So in these conditions, if there is a high risk of thrombosis, then we need to give them LMWH. But most of the time with antiplatelets, it is for these reasons, so we don't need the LMWH. Now, one more thing is that with a coronary stent in place, if we use LMWH, it does not take away the risk of the stent getting blocked. So we cannot just say that, okay, we are using heparin, so it's okay. We have to continue the antiplatelet agent. Now about bridging. Now, bridging is the term used for using another agent in between because of the high thromboembolic risk. So if it is a low thromboembolic risk, for example, if a patient is on the newer anticoagulants, and because she's on atrial fibrillation, so she's on prophylactic anticoagulation, or if a VTE or stroke was more than 3 months earlier, then you do not need to give bridging if the patient is on these newer anticoagulants. As I told you, you have to just stop the agent 24 to 48 hours before, so you don't really require any bridging. But if the woman is on warfarin and she has a prosthetic valve, or she has had a stroke or a DVT within 3 months, or a recent coronary artery stenting, and we are not able to postpone the procedure, then we need to use bridging. Most of the time, it is LMWH which is used. Unfractionated heparin can also be used because it has a short half-life. And if we are using unfractionated heparin, then usually in the perioperative period, an intravenous preparation is used. I'm going to talk basically about LMWH because I think in more than 95% of cases, what is used for bridging is LMWH. So if a therapeutic dose is required in high-risk patients, such as prosthetic valves or recent stroke or VTE, here you need to use, and it's best to calculate the doses based on the weight of the woman, rather than just a blanket dose of 40 milligrams in these high-risk women. Particularly in overweight women, many of our women who are undergoing surgeries are overweight or obese, and so it's good to calculate by kg body weight. So enoxaparin at 1 milligram per kg twice a day, or dalteparin at 100 units per kg twice a day. If the bleeding risk is high, then you can give them intermediate dose where you're using 40 milligrams twice a day or dalteparin 5,000 units BD. And if you're using it just as a prophylactic for low-risk women, then enoxaparin 40 milligrams once a day or dalteparin 5,000 units once a day. Now, the timing of starting the bridging is basically if for pre and for high-risk patients, for example, those with recent VTE, then you have to give it pre-surgery, pre-operatively, as well as post-operatively. So until the bleeding risk is much lower and you can restart the oral anticoagulant. In case of very high risk, where you've had the VTE in the leg veins, particularly the iliac veins, you should consider a temporary IVC filter. And if it is a VTE or a stroke, which is more than 3 months ago, then you could give them only post-operative LMWH. So if you've started the pre-op LMWH, as I said, when we stopped the warfarin, we started 3 days prior to surgery. Then 24 hours pre-operatively, we should stop the LMWH if it's an OD dose, or the previous night dose should be omitted if she's on BD dose. Post-operatively, 24 hours after the procedure, you can restart the LMWH or delay it for 48 to 72 hours if there is high risk of bleeding. Now, there was a lot of discussion about 5 to 10 years ago about using anticoagulants along with mechanical methods. But now almost all the societies, cardiology, chest, everybody is saying that it's best to use both mechanical methods as well as pharmacological methods. And if you're using mechanical methods, then rather than the graduated elastic stockings, it's better to have the stockings where you're getting the pumping. Now, for the reversal of anticoagulation, in case there are emergencies and you have to go ahead with the surgery and you don't have time for bridging, then for warfarin, it is vitamin K and FFP and then prothrombin complex concentrate if your blood bank makes it. Now, for dabigatran and rivaroxaban, there are specific anticoagulants, which if available, those can be given. But if those are not available, again, we have to manage with FFPs and prothrombin. Unfractionated heparin, we all know protamine sulfate is the antidote. But for LMWH, though protamine is not very good and we may need to use FFPs, protamine sulfate does give some amount of reversal of LMWH also. Now, this is important in our patients because most of us, most of our anesthetists would be using regional anesthesia. So if it is, if you are giving prophylactic dose LMWH, you should stop it 12 hours after the, it should be at least 12 hours after the last dose before the spinal or the epidural is given. So if you're using preoperatively, then please ensure that the prophylactic dose is stopped 12 hours before the spinal. You have to wait for 4 hours after the spinal before giving the next dose. And after that, the catheter should not be removed within 12 hours. So 4 hours after the spinal or epidural, you can give the dose if you feel that she's a high risk for clotting. You give her, but don't remove, if it's an epidural catheter, don't remove it for 12 hours after giving the LMWH. And once you've removed it, if you've not given that dose after 4 hours because she had a risk of bleeding, then once you've removed the catheter, you should wait for at least 6 hours to resume the heparin. If it's a therapeutic dose, then these 12-hour things change to 24 hours. So 24 hours after last dose before giving the spinal and 24 hours after catheter removal to resume the therapeutic dose. So these are important things to keep in mind because, you know, we just tell the residents to keep them on LMWH. And if these things are not taken care of, then we can have disasters, particularly with epidural because the needle is thicker. So in conclusion, it's important to have a multidisciplinary consultation. So it's important that in these patients who are on anticoagulants, we discuss with their cardiologist, with their hematologist and the anesthetist, and we all come to a consensus based on what the thrombotic risk is and what the risk of major hemorrhage is. It is important to time the surgery according to the anticoagulant, same with the anesthesia, and decide when to start the bridging and when not to. And there is no need to do all this in when there is very low risk of hemorrhage. The decision should be based on the type of agent, as I have shown you, and we have to be particularly cautious with regional anesthesia. Thank you so much.
Thank you, Dr. Jyoti. It was an exhaustive presentation. And you very rightly said in the beginning, this is something which we as OBGYNs don't know much about, because there are very rare clinical situations where we have to use it. I think a multidisciplinary approach is something which you very rightly pointed out, that we should be taking on board all the other allied specialists who would help in management of this woman. Are there any questions for Dr. Unni?
Shobana, you're muted.
Shobana, you're muted.
Dr. Neelam and Dr. Seema Sharma, both are from Medical College, one from PGH Chandigarh and one is from Jaipur Medical College. They have cases of this type they have handled. Can you please share us your experience? Neelam, are you there? Neelam will come at the time of
Yes,
panel.
yes. No,
Neelam,
I'm
you
here
start. Your
only.
senior,
Yeah.
you start. She's from PGH Chandigarh. So I'm very sure she has too many cases.
Yeah, Jyoti has given a very, very comprehensive and this review of the procedures to be followed at that time of surgery when a patient is on anticoagulants. Even though we are so much careful about the anticoagulation at the time of surgery and postoperative, I would just like to share with you experience of our one patient who was a double prosthetic valve patient, and she was on warfarin, right? Warfarin pre-operatively, and bridging therapy with Clexane was given. Patient was 45 kg, and so she was given 0.4 ml BD Clexane, and that dose was omitted on the day of surgery, and the surgery was done. And post-operatively on day 3, even though on day 2, again day 3, warfarin was restarted along with the Clexane 0.4 ml BD. So she developed aphasia and weakness of the right side of the body. So which was immediately picked up by the HDU team, because our residents are quite now expert in picking up complications of anticoagulation, because usually we are seeing the pregnant patients with prosthetic valves who are a very, very high risk challenging patients. Right, so they picked up immediately, and we have a stroke team. Stroke team reached immediately, and immediate NCCT head was done, and it was seen that there was a ischemic area, means cut off, the blood supply was cut off from the territory of mid MCA, right? So they were either there was a dilemma whether to give her thrombolysis or to do the thrombectomy mechanically by the interventional radiologist, because she was just third day post surgery. So the decision was taken for the thrombectomy, mechanical thrombectomy. So interventional radiologist, he performed the mechanical thrombectomy by passing the catheter guide wire through the MCA territory, and immediately this thing was restored, because this happened within 2 hours of stroke, and that could be done because of the
Okay, that's a good case.
Yeah.
I had the
So
other way
the
around.
patient,
I had a patient for whom I had laparoscopy posted for ovarian cyst oophorectomy, and she was on anticoagulants, bridging therapy, and everything. And the anesthetist refused to say, yeah, let me do it by laparoscopy. I don't know for what reason. And I opened her and I did it, and she had a re-bleed. And it was so difficult to take stitches. They bleed from everywhere. and
Yes,
it's very
yes,
difficult.
yes.
So I feel laparoscopy would have been better because that nice vessel sealing device would be there, and I feel it may not have bled. I don't know. Seema or anybody else, senior
Yeah,
sitting here?
actually, I also had a very interesting case. She was a case of prosthetic wall as Neelam madam's case, and she was on anticoagulation and she developed fever and some sepsis. And she was at the same time, PT, APTT were normal, and she developed swelling around the vulval area, and it was a quite big swelling. So they called me to see the patient and drain that, because to whom they shown, somebody told that it is a vulval hematoma and you drain it, and if you are not draining it, it will be difficult, it will further cause sepsis. But seeing into her whole profile, and the junior doctors had seen her before, but I was in the opinion that that was not a hematoma, rather it was vulval swelling due to this all cardiac failure and stasis of blood. So I did not drain it, and at the same time she was having consolidation in lung also. So after 3 hours of my consultation, they went for the CTVS persons and respiratory persons seen the patient, and they put this drainage for the pleura, drainage of pleura. They tried it, and the patient had a massive bleeding, and they could not even save that patient. Patient died itself during the procedure.
My
So
God, you have to be
sometimes these
careful.
things
That means.
also do happen. So we
Anyway,
have
it's
to be
not
very
easy to
careful.
handle. My God. Okay, over to you, Parag.
Yeah, yeah. Thank you, Neelam, and thank you, Seema. Thank you, Jyoti, for a wonderful lecture. Let's move on to the next presentation, and that's on control of AUB in patients on anticoagulants. And it's a pleasure to introduce Professor Girija Wagh, who is a professor at the Bharati Vidyapeeth Deemed University Medical College. Currently, she's the General Secretary of the Menopause Society Pune and Vice President elect of FOXY. Girija, the stage is all yours.
Good evening, everybody. If I can have the slide share. Yeah. Okay. So Jyoti has really given a wonderful clarity on a lot of things that can be used, and most of it can also be of reference and, in the same context. But our task today is to speak on control of AUB in women on anticoagulants. And in the next 20 minutes, thank you, Parag, for introducing me. And we've been knowing each other for the past 32 years. That is something that I must share here at the IMS. That when we are talking of anticoagulation associated uterine bleeding, we have to understand that many times we have to individualize the management. And the decision to withhold the anticoagulant should be based on the patient's risk of thrombosis and severity of the bleeding. And in cases of severe bleeding, it's always better to be in a joint care, because we just heard that there was a huge mishap, and such kind of things definitely should be avoided. And AUB HMG with ACT is always poorly reported. And that is a challenge, because that's the reason why there's a huge dearth of evidence to support these decisions. Much attention has been brought about at abnormal uterine bleeding associated with anticoagulation in now the FIVO 2018 consideration and guideline on AUB. And the crucial one is that it can lead to non-adherence or early discontinuation of anticoagulation therapy and may place women at an increased risk of VT recurrence. And therefore, a review of contemporary research reveals very little research available into this particular issue. So today I will be dealing with a few case situations: desired assessment before ACT, post-ACT AUB, that is ACT stands for anticoagulation therapy, evidence, and the treatment algorithm. Now let's look at this first case of a 22-year-old woman with recurrent unprovoked VTE, has heavy menstrual bleeding, and has reported to the emergency medical department. Since 8 days, she's having this bleeding. She was started on rivaroxaban 20 milligrams orally per day, 4 months, and because she had very poor INR control on warfarin. And after starting on this new anticoagulant, she had heavy and prolonged monthly menstrual bleeding. She developed iron deficiency anemia, and she was To reduce HMB, rivaroxaban was start for a few days during menses, and she developed recurrent pulmonary embolism. The scan was normal. LNGIS was tried, but there was no relief, and she reported a very, very poor quality of life. We are going to answer this question at the end of my talk about this particular case. And the second case is about a 44-year-old woman. Shortly after warfarin was discontinued, she developed recurrent unprovoked pulmonary embolism and was started on therapeutic doses of rivaroxaban. Coincident with initiating this particular ACT, she reported HMB. She described passing blood clots associated with abdominal cramps. An earlier pelvic ultrasound had revealed no structural abnormality. She required hospital admission and PCV transfusion because she had anemia. Again, we are going to discuss this case at the end of my talk. So what is abnormal is something that we all have to understand, and this is a wonderful guideline which has been given by the FIGO guideline as to what you call as abnormal. Everything that is seen on this chart in gray, and this is available everywhere on the Google, is called as abnormal. So anticoagulation therapy can be associated with any of this. There can be chronic bleeding, there can be intermenstrual bleeding, there can be an absolute acute bleeding episode with which a woman would report. And therefore, whenever we are looking at the abnormalities in the bleeding, whether it is HMB, whether it is IMB, many a times we have to consider, and we have to also rule out a coagulopathy apart from all the other structural changes. Now, this is a very wonderful display, and this is what is trying to show us. All those yellow marks are showing us the organic or the structural pathologies, while what you are seeing in all the blue ones or the green ones are the functional issues. And coagulopathy, endometrial issues, iatrogenic causes, not specified, ovulatory dysfunctions, all can affect women when we decide to put them on ACT for whatever reasons they have, and then they also may suffer from AUB. Now let's look at the evidence as we go by. So whenever we are looking and assessing bleeding of any woman, pan age, it is extremely important that we look at the red flags for coagulation disorders, because there can be thrombocytopenia, idiopathic thrombocytopenic purpura, there can be thromboasthenia, there can be leukemia, there can be aplastic anemia, and we have to be aware of these conditions. And therefore, whenever we have HMB since Minaki, more than one of the, then you can, or any of the followings, like she has history of PPH, surgery-related bleeding, dental work-associated bleeding, or bruising half times per month, or epistaxis 1 to 2 times every month, frequent gum bleeding, or family history of bleeding symptoms, we must immediately have our antenna shaking and try to find out. So this can be a part of your important history taking. And bleeding can also be present from sites other than uterus, such as ovary, cervix, vagina, vulva, GI, and urinary tract, and needs appropriate assessment and treatment. And this is something that we need to remember. Now, this is a wonderful algorithm, especially when a young woman who is a menstruating woman comes to us, then we must consider using some bleeding assessment tools. I'm going to share one with you as we go by, and that will categorically help us in identifying what is the bleeding disorder. Additionally, we have to take recourse of finding out which would be the approach. Naturally, the first trial would be the hematological test, look at endocrine and gynecological tests, especially pregnancy test. Bleeding disorders need to be evaluated by looking at various factors, and the commonest one usually will be the von Willebrand's defect, and then clotting factors and deficiencies. And then, of course, the second tier, if all these things have come up or they are, sort of elusive, or maybe to reiterate these findings. And then the medical management will consist of hormonal pills of various kinds, antifibrinolytics, correcting the anemia, psychosocial, understanding of this, and nutritional assessment, especially when they are cachexic or overweight. Now let's look at the questions that come to our minds typically. Does anticoagulant use really cause HMB? And let's look at what evidence we have. So we are definitely concerned that when you give an oral anticoagulant, there is a possibility that the woman will have abnormal uterine bleeding, which will be heavy, and interruption of the anticoagulant, and that gives rise to clot recurrence, and that is our concern. Now, what are the anticoagulants that are commonly used? Now, if you look at the various anticoagulants that are commonly used, there is the VKA, that is vitamin K antagonist, and the commonest one is warfarin. And this is something which is very commonly used. We saw that wall replacement. And it was found that unfortunately we have to find alternatives because warfarin requires a constant INR to ensure that it is in balance. So HMP with varying definitions has been reported with the use of VKs, and incidence has been from 22% to 65%. And a retrospective study reported an increase in HMB from 44% to 71% of patients before and after treatment with VKs, significantly increased the duration of menstruation, flooding, passage of clots, and intermenstrual bleeding. Now, so what we have commonly, which has been used, is rivaroxaban, that is Xarelto. And let us look at this. Now, this gets classified as direct oral anticoagulant. And the incidence of HMB in women treated with rivaroxaban ranges from 20 to 27%. A post hoc analysis of the cohort, and there are innumerable studies which have been done, but all of them have a very small cohort size. From the Einstein DVT-PE study found that AUB occurred more frequently in the rivaroxaban group compared with the LMWH or the VK group. And German registry demonstrated that frequency of vaginal bleeding, both cycle-related and non-cycle-related bleeding, was comparable for all factors XA inhibitors. So this was what was found, and they also had rivaroxaban, which had about, you can see the 30% of the bleeding was because of rivaroxaban, and 28% of the 18 with apixaban, and one, that is 25% of 4 with edoxaban. So there are various alternatives. What we have to remember that they can cause bleeding, and that is something that we have to educate the patient as well as the hematologist should be aware of that along with us. Now, there's another study, the Recover and the Remedy studies, where post hoc analysis of these studies suggested that dabigatran carries a low risk of uterine menstrual bleeding and a continuous, menstrual bleeding, about 4.7% than warfarin. And AUB occurred more frequently in the warfarin arm than in any other study. Now, what are the other options that we use? And we had Jyoti telling us about the unfractionated heparin and LMWH. Theoretically should influence menstrual bleeding like that of other anticoagulants, but there are no studies were reported or specifically investigated the effects of this on menstrual bleeding. And the effect of UFS and LMWH on bleeding will be difficult to evaluate because most of them are used for a short duration and are at prophylactic dosages as we would do before a surgery. And usually patients who receive the therapeutic dosages are usually for the post-cancer patients or in the context of pregnancy, where we cannot representatively use them for regulation of menstruation. So if we decide to look at the relative risk of HMB by choice of oral anticoagulants in women aged more than or equal to 18 years of age, it would be warfarin 4.5 to 9.6%, apixaban 5.4%, edoxaban 9%, rivaroxaban 9.5%, and dabigatran 4.7%. And you can see that rivaroxaban and dabigatran seem to be having a little larger association along with edoxaban. So answer to the question, do anticoagulation cause HMB? HMB associated with anticoagulation use is common. Current evidence suggests that the direct factor XA inhibitors may be associated with a higher risk of this complication than warfarin therapy, but the risk may be lower with dabigatran, and more data are needed to confirm this hypothesis. So let's look at the clinical challenges and practices. Many women do not report because they have not been told that this can be abnormal. Many clinicians do not inform and usually will report in acute conditions. While we are starting this therapy, it's important to talk to the patient and counselor. And therefore, it's always a good practice to inform them. And it's always a good practice to do a gynecological evaluation before any anticoagulation therapy is started. So that is a very important message, which we must share with our colleagues who would start patients on anticoagulation therapy. So when we look at the various clinical and laboratory features associated with HMB and or increased menstrual blood loss, we all know, and we are proficient with it as gynecologists especially, that we have to look at changing protection more than hourly, clots more than 1.1 inch in diameter, and low ferritin. And this is a classical and a very categorical way in which one of the studies in hematology has identified. And I think we can also use this in our practice. And features associated with increased mean MBL would be subjective report of very heavy bleeds, hemoglobin less than 12, need to change protection during the night, leaking through protection, and need to wear double protection. And you can see that they were not very significantly found because women probably were extremely tolerant. So if you look at the definitions of terms, we have to be categorically using them correctly. HMB when there is heavy menstrual bleeding, and you can consider using a pictorial blood loss assessment chart score. And if it's found to be more than 100, then it is definitely HMB, because sometimes patients are very anxious and they may say, bahut ho raha hai, so you must be able to categorize it objectively. Then abnormal uterine bleeding, where the menstrual bleeding is of abnormal quantity, duration, or schedule. And clinically relevant non-major bleeding is one classification, where uterine bleeding that requires medical intervention by a healthcare professional leading to hospitalization or increased level of care or prompts a face-to-face evaluation. And major bleeding, where uterine bleeding that is fatal or causes a fall in hemoglobin of more than 20 grams per liter or more than 2 grams per deciliter, is easy for us to understand, or leading to transfusion of more than 2 units of whole blood or packed cells. So the assessment of heavy menstrual bleeding itself is definitely a challenge. And therefore, one can use this International Society on Thrombosis and Hemostasis scientific and standard committee bleeding assessment tool. And this, when categorically measured, will help us in guiding how much is the bleeding and how much she has responded to treatment. And that also helps patient to understand that she's having some relief. Now let's look at what are the options that we have for treatment. Now, combined hormones is some treatment. And the moment I say combined hormones, I'm sure that all of your eyebrows have gone into the hairline. But let us look at what the evidence is saying. Although not studied in women who received anticoagulants, the use of cyclical hormones significantly is known to reduce HMB, we know, and improve the hemoglobin. And combined contraceptive patches or vaginal rings have not been specifically studied with HMB. Major side effects of COCs include breakthrough bleeding, nausea, and we are very, very well versed with them, and bloating, especially abdominal. And the most adverse effect with extended or continuous COCs is breakthrough or vaginal bleeding. Now, another option which we have is the progesterone-only pills. And these have been found to be effective as contraception, but have not been studied for the management of HMB. And there is a meta-analysis which concluded the use of short-course cyclic high-dose progesterone, that is norethistron or norethindrone, 5 milligram given 2 or 3 times per day for 7 to 11 days for HMB treatment, was less effective than tranexamic acid, danazol, and the progesterone-releasing intrauterine system. An extended regimen, however, of high dose, that is giving norethistron 5 milligram 3 times per day. Now, fortunately, we have the slow release formulations of the same drug, which can be given in a higher dose, seem to be effective in reducing HMB, although it has not been again evaluated in women receiving anticoagulants. DEMPA is an injectable progesterone, which is used as a contraception, but can also be used for heavy menstrual bleeding. And short-term treatment also is known to reduce menstrual blood loss in perimenopausal women with HMB. Major side effects of progesterone-only contraceptives are irregular spotting and breakthrough bleeding, and other common adverse effects are weight gain, greasy skin, and so on. Now, LNG-IUS seems to be one of the most important drugs which has been studied in these situations, where the efficacy was being evaluated in patients treated with VKs and in patients with bleeding disorders, and there's only one RCT. And observational studies have shown a reduction in the amount and duration of bleeding with LNG-IUS. Only one randomized trial has been published, and that study enrolled 40 women with HMB receiving VKs after cardiac wall replacement and were randomly assigned to LNG-IUS or to a no treatment group. And there was a significant decrease in the pictorial blood assessment chart bleeding score and the number of bleeding days per cycle at 3 and 6 months compared with baseline pre-insertion. And the mean of HB and ferritin levels were significantly increased after 3 months. So out of all these options that we have, this one seems to be having the only evidence that is there in anticoagulation therapy. Now, risk of VTE is a question that we have in users of hormonal therapy during anticoagulant therapy, is a question that we need to answer. Because anticoagulants are known to reduce the risk of recurrent thromboembolic events, and recent evidence suggests that effects of therapeutic dose anticoagulants is sufficient to overcome the incremental prothrombotic risk associated with hormonal contraceptives. And in the post hoc analysis of the Einstein DVT and Einstein PE studies, women receiving HT, that is combined pills and POPs, during the anticoagulant period had a risk of recurrent VTs comparable to that for women not using hormonal therapy. And the results of that study, and this is something very important where I want to draw your attention, have challenged the WHO guideline for CHCs, which states that established VTs during anticoagulant therapy is a condition that represents an unacceptable health risk for combined hormonal combinations when used for contraceptive purposes. However, the results support the guideline of the International Society on Thrombosis and Hemostasis, which suggests that hormonal therapy can be continued in selected patients after the initiation of anticoagulation. Now, what do you do when a patient comes in an emergent management in acute bleeding stating? Should a patient continue anticoagulant therapy or should a reversal agent be used? Would a reversal agent increase the thrombotic risk? The answers to those questions are based on individual patient's risk profile. And in patients with hemodynamic instability from bleeding, the anticoagulant should be withheld and reversal agent should be considered. And other surgical interventions that can be considered can be balloon therapy, endometrial ablation, embolization, and hysterectomy if necessary. So I bring you back to case number 1, which I had proposed in the beginning, that at the EMD, her blood pressure measured 108 by 73. Remember, she was bleeding for the last 8 days. She had tachycardia. Her hemoglobin level dropped to 4.5 because her last thrombotic episode had occurred more than 3 months ago. The potential morbidity from bleeding was felt to outweigh the thrombotic risk, and therefore rivaroxaban was held. A single dose of tranexamic acid was given. During admission, the patient was transfused with 4 units of PCVs and a selective progesterone antagonist receptor was initiated. Endometrial ablation and hysterectomy were discussed, but you can remember that she was a very young patient if HMB should recur, and the patient was switched from rivaroxaban to warfarin. Subsequent visits revealed no further HMB. At present, the patient does not require further HMB-related treatment or surgery, and she remained on warfarin at follow-up several years after her bleeding event. So these are the ways in which we have to switch between and try to give them a balance. And the case 2, if you remember, was a 44-year woman. The patient developed HMB after being treated with rivaroxaban. We discussed switching to warfarin or an alternative DOAC, but she preferred therapy once per day and did not wish to undergo INR monitoring. Because her second VT event was more than 6 months ago, we advised the patient to decrease the dose of rivaroxaban to 10 milligram once per day after informing her that this was an off-label dose. And she was also referred to a gynecologist for further investigation. And with a reduced dose of rivaroxaban, her HMB was resolved. So we had one such similar case, and she had come to us with very, very acute bleeding and a condition, and was having a previous history of, you can see her that she was a very, as a young child, she was developed with, she had come to us with large cystic lesions in her abdomen. And the question was whether it is endometriosis, whether it's a hemorrhagic ovarian neoplasm, and that lesion was quite large. Now, she had a preceding diagnosis already made of Lanzmann's thromboasthenia, which is an autosomal recessive X-linked disorder, defect in platelet aggregation, and her incidence is very, very rare and is very common in females. And usually they have excessive bleeding from minor injury sites. And here in this patient, she was bleeding from her ovarian site. And she had, why? Because she had stopped her COC. She got very tired of using those combined pills. And one day she said, "Main band karke dekhti hu kya hota hai," and she stopped it. And then she started getting this bleeding. The puberty menorrhea initially resolved in COC. And then she had menorrhagic cycles post withhold of COC. And she also had second degree consanguinity of parents and grandparents. Then what did we do? These were her past reports, which showed us that she had the von Willebrand antigen 83%. And ristocetin cofactor assay of 145%. We took hematological opinion, we gave her a lot of blood transfusions, and then we decided to, after 7 days, decided to post her for surgery. And this was the laparoscopy which we had done. Dr. Shobna, you did mention one such thing, and this was what we saw inside. We only just did a clearance. We were giving her platelet transfusions, did the clearance, put in a drain and came out. And after that, we put her on combined oral contraceptive pills. And this has been about some 10, 11 years back, and she's still doing well. So whenever we are looking at patients of HMB on therapeutic doses of anticoagulant therapy, do a proper clinical assessment, intensity of anticoagulation therapy, assessment of iron depletion, review need for ongoing anticoagulation, give them therapeutic dose anticoagulation if it is needed, Referral definitely has to be there to a gynecologist, consider alternative causes of HMB, initiate or adjust hormonal therapy. And if she is receiving hormonal therapy, such as combined pills, POP, DEMPA, and then continue therapeutic dose anticoagulation, consider switching to alternative anticoagulation like apixaban, dabigatran, or warfarin, and you can use tranexamic acid in the middle. Not receiving hormonal therapy or on LNG-IUS, continue usual therapeutic dose of ACT and use tranexamic acid 1.3 grams orally 3 times a day for 5 days and start on the first day of menstruation, or reduce the dose of the oral anticoagulation. Maybe as you saw in the second case that I described, like you can cut them a little in the dosages or consider switching to an alternative anticoagulant therapy. So you can either reduce or change to another anticoagulation therapy. So in conclusion, we have to remember that whenever you are considering at any point, we have to have gynecologists there always pitching in, and we have to therefore through our especially IMS society, we can consider using this as an advocacy to our hematologists and physicians about this. Evaluate the ferritin status and supplement with iron as needed. Discuss the importance of contraception. If prior to OAC therapy, first choice, continue previously prescribed therapies while on OAC, LNG-IUS, select lower risk OAC. Second choice would be a subdermal implant, POPs, DEMPA, or begin OCs. If more than 1 month of OAC therapy is remaining, then again LNG-IUS would be your first therapy, and the similar options can be considered. If it's severe or refractory HMB, maybe we'll have to consider a surgical intervention. If less than 1 month of OAC and therapy is remaining, first choice LNG-IUS, observation, supportive care. Second choice, select lower risk of OAC, subdermal implant, severe refractory HMB, and tranexamic acid considered. Gynecological opinions are essential because there can be so many issues that can be there, which may be presenting and causing confounding things, and we can treat them in a better way. So this is what I had to say at the end, and thank you for giving me this opportunity. And I hope I have done some justice to whatever was told me. I have categorically not spoken on low-dose aspirin and the clopidogrel because they are basically platelet inhibitors. I only have focused on anticoagulation therapy. Thank you.
Thank you very much, Girija. It was indeed a wonderful presentation. Though these situations are rare, but then you've really given us nice clinical pulse into the management of such women. And you very rightly pointed out that, you very rightly pointed out that the drugs that we have with ourselves, the DMPA, the POPs, the COCs, and even the LNG-IUS have to be experimented in the right patient at the right time in order to control her bleeding. And one more thing which you pointed out, which is again so relevant, that we tend to use suboptimal doses of tranexamic acid. We have to remember that the recommended dose is 2 to 4 grams per day. Your slide mentions 1.3 grams 3 times a day, which is nearly 4 grams. But we tend to, give much lesser than what is recommended. So using the right drug in the right dose at the right time is a very
We're a little
important
scared of using tranexamic acid for these cardiologist patients. We are so scared.
Don't tell us.
But now she's telling you must give it.
Yeah.
Can I also share one of my cases? Can I share one of my case?
Yeah.
Yes.
Yeah, so I also had a young girl. She was 21 years old, unmarried girl. She came to me with massive hemiperitoneum. So we found it ultrasound. We did a CT scan, everything confirmed. We did her clotting factors, PT, whole clotting profile. Everything was normal. Everything was normal. So we did an ultrasound. We did a laparoscopy. Her whole abdomen was full of blood. We didn't know what to do. When we washed, cleaned, we found that she had this ruptured corpus luteum.
I also had one like this.
Yeah. So we
ovulation bleeding in patients on anticoagulants, and laparoscopy shows only that point is bleeding.
So I coagulated that area, and then because she was a young girl, I put in a drain, came out, put her on COCs, and she was in touch with me for 6 months. She was fine. Suddenly, after a year, she came back to me with almost similar complaints. She had this distended abdomen, very painful, this hemoperitoneum. So we went in to check in for other, clotting factors.
he found out that she had congenitally absence of clotting factors in her. And in that case, we explained to her that, this is a risk which you will carry all your life. So you have to be very, very careful and plan your pregnancy with a hematologist when you become pregnant. But then after
And a gynecologist, not only hematologist, and a gynecologist.
Yeah. But she did not come to me after that. After 6 months, she again disappeared.
He went to Girija.
No, she didn't. Tell you, Dr.
These
Soni,
are some of the cases which you can face in your lifetime, and they really make you so much, give you so much of stress, and you don't know what to do in these cases.
Yeah.
One of IMS to discuss, but Dr. Soni, I must say that your patient was very lucky. She came to you. She did not go to any surgeon because she would have landed up in castration. Maybe a oophorectomy, something is bleeding from there. Maybe another. This has happened actually in real time. And therefore, because of you going in there, you diagnosed and saw. And we all know, the Spiroff's textbook mentioned the most vascular organ in the woman's body is the corpus luteum.
Oh God. I didn't know this.
Yeah, per unit, Mahek.
I only see cases bleeding from there, but I didn't know Spiroff went to that extent of talking.
Was as full as a ruptured ectopic.
Yeah.
So I thought, she may be lying. Like one patient came to me with the massive hemiperitoneum, and she had this. She had taken 3 times this Safe Abort kit, and did not tell her parents that she was having sex with someone. She was pregnant, and when she came to me, her one horn was ruptured, which was probably small or whatever.
Okay, now we will leave obstetrics out of this because we are running out of time. So over to Pune. We will, after the panel discussion, as long as Clearnit allows, we will have discussions.
I think Meeta wants to make a comment. We'll take that and then we'll close this discussion.
Sure.
Yeah, thank you, Parag, for giving me the opportunity. I just wanted to say similar episode I had, but I'm not going to talk about it. LNG, and that girl had, factor VIII deficiency, and finally she also delivered later on. Anyway, I just wanted to ask Girija, tranexamic acid, it's per se also is thrombogenic. And again, here OCPs are thrombogenic, especially the estrogen content. I mean, in the RCTs, well proved. Now, though, you've put in a lot of good evidence, it still fails to, I would still be very hesitant to prescribe OCP or a tranexamic acid to a patient sitting on front of me with, this bleeding plus the LNG, probably, the first choice, second choice, plain progesterones rather than even the other progesterones, either plain dydrogesterone or even DMPA. So I just wanted, your opinion on this.
I completely agree with you.
Good input,
I
Meeta.
will
Very good
always
input.
be hesitant using a tranexamic with a COC. So first approach is always using a tranexamic acid with a mefenamic acid first.
She's giving us guts to do that. We were all scared.
Yeah. And then after that hemorrhage stops a little, you can start a high dose levonorgestrel or high dose norethisterone. Start it on a high dose. And don't
we always do it.
Just a minute. That norethisterone is supposed to be, more because of the little bit of an estrogen content there, more thrombogenic. So norethisterone is, little dicey because I have had one case whom I lost. Obese lady, norethisterone, self-medication, and she had pulmonary embolism.
Together.
My God.
Together. First, stop the bleeding with tranexamic acid, and then once this reduced, then you start on your progesterone or COC. Do not give
Very
them.
scary, Meeta.
One more thing about tranexamic acid, I'll tell you. I had this patient who had we did a myomectomy on her, and she used to keep on bleeding. No, I did a hysterectomy on her. She was 43. She used to keep on bleeding. When I used to write her tranexamic acid, she used to keep on taking her tranexamic acid. We did a hysterectomy, and she insisted that she wanted a laparoscopic hysterectomy for a massive fibroid, and she wanted the cervix to be kept behind. Now we did morcellation, we did the hysterectomy, everything went well. She was discharged at 3 days. After 1 week follow-up, she came to me saying that she had bruises all over her body. I was scared. I said, let's get your CBC done. And platelets, have you heard platelets being 15,000 to 18,000?
Yeah.
15 lakhs to 18 lakhs. That was the platelet count. I was so scared. I called the hematologist. He said, don't worry. It is just the reaction of the body. And she was taking tranexamic acid incessantly herself, Plus, right now she's undergone a surgery, so this will take a little while to wane off.
Oh, tranexamic acid can increase your platelet count to that level. My God, that's real knowledge.
I'm wondering whether it happened because of morcellation, kya na, all kind of.
Morcellation is not going to increase. Yeah, bruising. Yeah, bruising you get scared, na, because हमने क्या किया?
हमने क्या किया?
बस होता है. Yeah,
Thank
chalo,
you,
we'll
thank
go.
you, Girija. It was a wonderful presentation. Tanushree, over to you for the next session. Thank you.
Yes. Thank you, the speakers, and thank you, Parag sir, for chairing the session. We now move ahead to the panel discussion.
Please introduce the panelists because you know them more. Except for Jyoti Chandran and Anju Soni, you have to introduce the panelists.
Okay. As a moderator, we have Dr. Shobhana Mohandas, our own President, Indian Menopause Society. She's a chairperson for Women's Doctors Wing, IMA Thrissur.
No, you leave it. I am introduced every week. Forget.
Okay. Just a second.
Dr. Shobna, meanwhile, you can start sharing your panel. Start sharing the screen.
No, but do they want to share the CV of the panelists? Tanushree, are you sharing the CV or shall I?
No, the technical person will share the CV, I think. There's a message from Dr. Vaishnavi.
Technical person, please share the CVs if you are still around. She changed this now?
Dr. Vaishali Kodinayak will not be joining because she's stuck in an emergency surgery, ma'am.
Jyoti is also going out, so the remaining 4 will have to take out. Okay.
Yes. So Dr. Kiran Kurtakoti is ex-chairperson MTP committee FOXY, ex-chairperson medical education and research training AMOX.
He's vice president of AMOX, Tanushree.
Yes, he's vice president of AMOX.
Tanushree, okay, get on with the next one. Thank you.
Okay. Dr. Arundhati Kanade. She's a consultant OBGY, Dinanath Mangeshkar Hospital and Research Center. Dr. Mehak Mukhi, working committee member of Pune Menopause Society and consultant OBGYN in Jahangir Hospital. Dr. Anju Soni, chairperson HIV AIDS Committee FOXY, Secretary General Indian Menopause Society.
Okay, it's okay. You can go further.
Yeah. Dr. Jyoti Chandran. She's a professor and HOD, Government Medical College, Kozhikode, Kerala. President Kalikat OBGY Society and of Indian Federation of Gynecology and Obstetrician.
She has been the president of KFO for a long time. She's a president of Calicut Society for a long time and is highly academic and sought after teacher. So I will start with the panel now. So good evening, ladies and gentlemen. After those heavy board talks, I will have a very simple panel here. And I don't know, I hope it's also useful for your day-to-day practice. Jyoti has to leave. So Jyoti, you start with your first case. A 40-year-old girl comes with bleeding per vagina, 10 days and changes 4 pads per day. Ultrasound shows normal sized uterus and ovaries, thyroid and everything is normal. You know, she had menorrhagia since 16 years, she says. I don't know how much to believe. She used to get settled on OC pills from medical college, but now she doesn't like the medical college people. She says, I'm getting severe cramps with OC pills. You know, is the medical college people who gave OC pill wrong or what is it? Or is it the withdrawal bleeding giving cramps? Estrogen is giving cramp, progesterone is giving cramp. What to do when she gets cramp with OC pills, Jyoti?
First of all, I'm very happy that you called a 40-year-old girl.
Sorry.
We
By mistake.
are all girls.
Yeah.
In spite of being members of the Menopause Society.
Yeah.
This patient is on long-term OCP, and we understand that the progesterone component in the OCP causes desterilization of the endometrium. And just like we find patients with ectopic pregnancy having a pain and passing a fleshy mass, after that the pain disappears, we say residual cast. Similarly, when this desterilized endometrium sheds, it produces amount of cramps. So it is the progesterone which is responsible for this cramps.
But now she's blaming the OC pill. So what to do? So what would you do with a patient who says OC pills? Is it the medical college or is the private person can give OC pill without informing her? What would you do with her?
Put in an LNG IUS.
Okay, that's the best part. Anyway, those were the times when they were not, I was giving talks on diosmin with Walter Bushnell, and then I was very fond of this drug, and I had seen that talk, and I was giving diosmin. So she was given diosmin, and I gave norethistron, even though it is a decidual cast and everything, whatever the theory says, norethistron was given, and diosmin on the days of the bleeding to be continued for 3 months. Unfortunately, she didn't understand what I said. She took both together for 3 months. And she says, no problem, now I don't have. So what is theory and what is practice? Progesterone is causing decidual bleeding, and here is a patient who is put on progesterone by mistake. 3 months she takes it, and then she says she has no bleeding. So should we revise our thoughts processes? I don't know. So you would say that you would prefer levonorgestrel IUCD for patients with cramps, right, Jyoti?
Yes, ma'am. And also regarding diosmin, it is a flavonoid, and what it does.
That's one thing which it, stabilizes the venous tone. Unlike tranexamic acid, which increases platelet count, diosmin stabilizes the venous tone. So it will stop bleeding. That's used in piles also. So that's why it stops bleeding.
And they say that the oranges, citrus fruit, they all contains this flavonoid. So increased intake will also help them in stabilizing the venous bleeding.
So Nagpur people won't get any bleeding because they have a lot of oranges there.
Yes,
flavonoids. It's the rind of the orange, not the inside part that has diosmin. What about desmopressin, Jyoti? Have you ever used desmopressin in patients in anticoagulants? Nobody mentioned that actually.
We have used it.
You have used it on patients in anticoagulants?
Medical people have used
it. Achha, how much do you use it? Just out of the box now.
it.
Two puffs in the nose. How many days you use it? It's a nasal spray.
I don't remember the
You
dose.
don't remember. It's actually 2 puffs per day for all these patients and anticoagulants when they come with severe bleeding. Diosmin is one option if you're scared of using tranexamic acid. Girija says don't get scared. But otherwise, diosmin is another drug that can be used in these cases, I think. Now I'll come out with the next case. 42-year-old housewife was admitted to the stroke unit with the onset of left-sided numbness and mild weakness. She was otherwise healthy with no history of any previous medical problems. She had taken OC pills to cease the menstrual cycle, because she wanted to go to Hajj. And it was revealed by the husband that she had been on oral contraceptives for several days. MRI of the brain showed small parietal stroke. So who are the patients liable to get thrombotic events with contraceptives? Dr. Naik. Is she here?
No, she's not here.
Not there. Can I take this, Dr. Shobna?
Okay. Yeah, tell me, Anju.
All
Who can
patients-
take OC pills while going to Hajj and who can't take it? Yes, Anju.
There are patients who are obese and who are, am I audible? I think my
Yes, you are audible, Anju.
So maybe I switch off my video. That will be better. So
no, we can hear you.
Yeah, okay. So basically the patient who are, most of the ladies who are obese, and what happens is that most of the patients who are obese and who basically take these drugs for a longer time on their own convenience. We find a lot of patients, they have to do some kind of puja or some kind of, festivity. So they take on their own, then they take for a longer time. So, and we all know that, in most of these periods, it has norethistron, which is again a huge problem. And we all know that they cause a higher, there is a risk of stroke and myocardial infarction in this patient, which is
obese
quite high.
patients and previous history of stroke should avoid it.
Yeah, avoid. Yes.
Yeah, there is a large trial called as the mega trial. So this mega trial, which was done way back, I think in 2009, this clearly stated that the risk was a very high, at least 3 to 4 fold. And what they found that even if you lower the dose of ethinyl estradiol, okay, even if you lower it from say 30 to 20, then the risk was same. So there was no difference between the low dose ocipin and the normal dose ocipin.
Okay, so you should use a lower dose.
You should use lower dose, but again, the risk is still remains. So many a times there are a lot of gynecologists, especially those who are practicing IVF, or those who use OC pills in patients with say low AMH or to suppress for pituitary suppression. Initially, they give OC pills along with ecosprin.
Oh,
they give OC pills along with ecosprin because what they
that much scary that you use an OC pill. You have to give ecosprin with it.
Yeah, I'm just saying that there are few people who are doing that.
No, we should know that these things are happening in the world. No, we didn't know this.
These are definitely happening. Of course, with not those in whom we are giving OC pills as contraception, but in those in whom OC pills are given for pituitary suppression before IVF stimulation.
And in the indicated ones, like how Anju Soni is saying that obese ladies history of stroke, or somebody else has got stroke, somebody where you're scared, you can have this new option that you give ecosprin along with it.
Yes.
Very nice input. Very nice input.
Thank you.
So now a 40-year-old woman with a large fibroid causing menorrhagia comes with acute menorrhagia. She doesn't want immediate surgery. You know, once she had come, she was given norethistron or something, and it's got control. Now she's again back to you. Hey, come on, give that to me again. You know how to stop my bleeding. Come on, stop it for me. Is it possible to stop it every time they come and talk like this?
No. Yeah, can I take that?
Yeah. Yes, Dr. Kiran.
Now, if at all you go to the newer classification of fibroids, especially these two type 2 fibroids which are jutting into the myometrium, okay, into the more than 50% into myometrium, there is no point in giving them either OC pills or progesterone or LNG-IUS. Straightway.
That we all know, but the patient is refusing. She's saying, once you stop with progesterone, will it? You give me progesterone, don't give me mifepristone, don't give me ulipristal. You stop with norethistron, you give me again.
What we can do is we can just show her this particular scholarly article which will say that progesterone receptors will be saturated at a point of time, and then let it stop, no use at all. So probably only counseling will work in this particular case. And what I do for my patient is I show them index journals.
Oh God.
Yes,
my God.
Index journals, because you know, we have people who come with they do the Google surfing. They do not know what to surf Google scientifically.
Yeah.
So what I tell them that if I'm going to make any presentation, this is the work which I do scientifically. I make scientific presentations. So you go to the NCBI website, or you go to the PubMed, or you go to the Cochrane database, and then you search. There's no point in searching for a layman's article. You search whatever experts are doing. You do a Google search in that way. So I show them, I give them a index journal. So they go to the index PubMed journal or the Cochrane database, and then it is for them to decide. And you print it on your paper that you
basically the receptors might get clogged, so every time the magic won't work.
Yes.
But quite often it does work, no, Dr. Kiran?
Yeah, so
very rarely it doesn't work.
Yeah,
no?
Quite often.
What is your practice?
Yeah, every time you can't take a pigeon out of a hat. Sometimes nothing is going to come up. Sometimes someday or the other it is going to stop. Okay. You just have to stay put.
Okay.
Yes.
Okay, now Dr. Arundhati Kannada is there?
Yes, madam.
Yes. Okay, now a 51-year-old woman, now these people are very commonly not getting menopause even after 51. BMI 31. She is on ACE inhibitor. I think ACE inhibitors are getting replaced by other drugs nowadays, but old times, you know, she's a perimenopausal with heavy, irregular, unpredictable periods. she's got hot flashes, night sweats, and poor quality of life. So will you easy work is giving OC pills? Will you do that?
No, I
Or
will. And instead of OC pills, we will prefer to give menopausal hormonal therapy. And so the HRT, which we used to call in the olden days MHT, and in which we use a low dose estrogen, and with progesterone, which is either natural micronized progesterone, dihydrosterone, or we can put estrogen with Mirena inside, LNG-IUS.
okay, why did you say that? Why did you not give one OC pill and everything would have worked for her?
Because madam, as time passes, the risk of OC pills with hypertension will also increase. So in certain contraindications of OC pills, it does cause DVTs, and that can create problems due to her age, one, and second is her hypertension.
So age is, I think, okay, but then there is an increased incidence of DVT with OC pills because each tablet of the OC pill contains 4 times more estrogen than the estrogen contained in the MHT.
Yes.
So it is more estrogenic, and therefore there is more risk of causing DVT compared to the normal estrogen in MHT. So the clear-cut message is we cannot give OC pills in this particular group. So now we have had a whole talk on this topic, but still I just want to ask this to Dr. Mahek Mukhi. To summarize what Girija Walk said, many patients on warfarin for various heart diseases sometimes get heavy menstrual bleeding. Can you use progesterones or oral contraceptive pills in these patients? What did Girija tell us?
Yeah, like you said, ma'am has already given us quite an extensive and beautiful lecture on it. So there are enough RCTs showing us that there is no contraindication to using COCs. But if you look at her case, ultimately what I think the take home from ma'am's message whole talk was that you want to give her something that she's going to be compliant, which she's going to do. So I think in her case, I would like to use an LNG-IUS, because that's going to give us a long-term control, because she is going to have recurrent episodes of heavy menstrual bleeding. So put her on a LNG-IUS so that we have a control on the bleeding in every cycle.
Okay, thank you for that message. Now I come to Anju Soni. Quite often some patients come with a piece of, some triangular piece in a bottle. They have been on norethisterone therapy, and then she says, oh God, what happened? And sometimes when you're doing a DNC, it looks like a product of conception. बाहर आते ही रहते द्रौपदी वस्त्राक्षेप का जैसा बाहर आते रहते बंद नहीं होते. What is it?
My question has already been answered in first question only, that this norethistron has got a very good quality of decidulization. Basically, it has got estrogenic as well as progesterogenic nature, and it gives rise to decidulization of tissues initially, and later that is followed by decidulization. So whenever a patient who comes to us with the who is,
have you had patients coming with that piece in a bottle asking you what it is?
Yes, of course, especially after ectopic pregnancy also you get these cases.
No, not ectopic. I'm talking of normal DUB patients coming with this piece of.
What I am saying, this is a
even after ectopic they come with that piece, huh?
Yeah, because there is decidulization of the endometrium.
Oh, okay. Yeah. I had patients after DUB coming with these pieces. You had patients after ectopic coming like that.
Yeah, so basically it has got estrogenic effect, little estrogenic effect also, norethistron, and also norethistron basically gives rise to first, the patient who are like in DUB in perimenopausal age group are mostly highly estrogenic. Their endometrium grows, and we give them this norethistron in a higher dose and slowly taper it. But this basically leads to decidulization after the glandular atrophy, and when this occurs and there is a break, then this whole thing comes out.
Okay.
Yeah.
So sometime in the middle of the night, they'll give you a call saying, I've got severe abdominal pain. It's all because of your medicine and things like that. And you have to send them to the casualty, give injections, and these things happen sometimes, no? Yeah.
Yes.
So now we will go on to the next question. Anybody can take this. If Jyoti Chandran is around, she can take it. Otherwise, Bloating and fluid retention after MHT in your practice. Are you there, Jyoti? Otherwise, somebody else can take it. How often do you find patients like that? They have to change their blouse and things like that. If that happens, change of churidar, change of blouse, because MHT liya hai to blouse badalna padta hai.
Fluid retention is very, very common in most of the women, even in premenstrual syndrome also, because we all know that progesterones are very, very, popular, giving rise to fluid retention, bloating, and, all these problems. So we have to switch these patients to the doses which are low in estrogen and low in progesterone, or maybe we can shift this patient to microgenized progesterones. So that there is no fluid retention, and of course to give them a good diet, less salt, taking less salt, no caffeine, less amount of caffeine, and that will really help.
Okay. So now next question was supposed to be for Dr. Naik, who is in an emergency. Anybody else, Dr. Kiran or anybody else wants to answer? Breast tenderness is very common on MHT. What do you do when they come like that? Otherwise, Anju can take it. Is anybody else ready to take this question? Okay, Anju.
Yeah, basically again, the same problem is with estrogens. When you take the estrogens, as in premenstrual syndrome, there is tenderness in the breast, fluid retention. So, restrict the salt intake, cut down on caffeine and chocolate, and change the progesterone. So again, low dose thing, similar thing.
I sometimes give vitamin E for these patients, primrose oil, all that does help for me. In my patients, do you also do that, or only cutting down
In
those?
these patients, what I have seen is, especially in PMS patients, what normally we give them this B-long tablet, B6 and B12.
Yeah, that is for premenstrual syndrome.
Yeah,
but,
that also
for
helps.
MHT mastalgia, also it helps?
Yeah, it helps. I have seen it helps.
Okay,
In
so
those
B6.
patients also. And when you go into the depth of these patients and take the past history, they will come out and tell you that they used to have this problem earlier on also. So
Okay.
I have seen that.
So Jaipur B6, Kerala vitamin E, and definitely they reduce the estrogen that is there. Okay.
Yeah.
So now in women with epilepsy on OC, we quite often have these patients. Dr. Kiran, can you take OC pills if you have a lot of epilepsy patients these days? No, they are all doing well. What do you do?
Yeah.
Not that you have to look at their prescription and find out if they are on OC epilepsy. They may not even inform you. Chupa rehte hai wo.
Yeah. Now, before I answer this question,
Yeah.
in the previous question, normally we also give tablet B-long. B-long.
Yeah, that is a B6 now.
Yeah, in high doses that should help. And one more thing that we help.
High dose means what? What is high dose of B6?
One tablet.
BD?
BD.
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 Okay.
Yeah, BD. And also, at times, what we have found out is we just ask them to switch over to a sports bra. Usually, that also changes a lot of things.
Okay.
Okay.
Oh.
I don't know whether many of you whether you are prescribing it that or not. But
I've not thought about it. Maybe this is something that I've learned from Pune.
I know. But
that's
yes,
why we have webinars.
They do have a good effect, because the support is much better with that rather than with the routine underwire support. Okay.
So a well padded bra, preferably
No, I'm not talking about a well padded bra. I'm talking about a sports bra. It's a totally different thing from the routine one which they use.
Okay.
Yeah.
So we'll have to look at it. Thank you for that input, Dr. Kiran.
Yeah.
Okay.
So now coming to this epilepsy, yes, we do get quite a few cases. Now what we need to do is coordinate with the neurologist and just change the dose of the anti-epileptic drugs. That's the only thing that we need to do. And in case, if at all, in few cases we have found out, just to match the liver functions when we are giving high dose OC pills along with the anti-epileptic drugs. That's the only thing that we need to do.
Okay. Thank you for both the inputs, Dr. Kiran.
No, I just want to add, Dr. Shobna.
Yeah.
Whenever you are giving OCPs, we have to take history of many things. We have to examine the patients in detail, take their history, whether they are any history of hypertension, epilepsy, they are taking some other drugs, which may interact with the
I know we never take history properly when they come for OCPs.
Anti-tubercular
It's
drugs.
missed out quite often.
Yeah. So it is very, very important to take history of other drugs which are taking. Sometimes they are taking these herbal drugs which may have the negative effect, which may decrease the effect of the estrogen and progesterone. So it is very important to take the history of the drugs which
तो
they are
बचपन में हम लोग को हमको सिखाया था पास्ट मेडिकल हिस्ट्री लो, फैमिली हिस्ट्री लो, कभी कभी BCOPD में you forget all that, but you must take history of all these things because epilepsy will recur otherwise. Hypertension है तो DVT आ जाएगा, so you have to take a proper medical history. Yes, Dr. Mahep Mukhi, what about migraine? What will happen to migraine after menopause? If she needs HRT, can you give it?
Yes, ma'am. So essentially after menopause, because there's a drop in the estrogen levels and that cyclical hormonal variation.
So
there has been a decrease. You will notice a decrease in the frequency in which patients do develop.
One thing is after headache, no pad, no headache after menopause. No pad and no headache after menopause. Good, na? Okay.
And yes, you can give them MHT. In this patient, we would probably use a continuous combined preparation.
Because the sequential regimen causes fluctuations in the estrogen.
Variation.
There are continuous HRTs available in the market now. Actually, one company is giving it, Abbott is giving it, and it's finally available in India. So you can use that in these cases of migraine. That is what Mahik Mukhi is saying. Anyway, one thing to remember, even phytoestrogens can cause headache. That's not that MHT nahi hai, the phytoestrogens. Somebody has told me that using that also causes recurrence of migraine. So yes, it's definitely not a complete no. Now to finalize the panel, Anju, how often you get menorrhagia? Mein LNG IUD आपने कभी डाला है? क्या हुआ?
Yeah, I have used it in quite many patients. And normally I only put the LNG IUCD when she has basically, we stop the bleeding and I call her, I put her on OC pills first, call her on day 4 or 5 when her bleeding is on the, lower side, but not completely stopped. And then I put her LNG IUCD and I call her again, or not only LNG IUD, I call all my patients after first 1 month of putting any IUCD and check that whether it is in position. And then again, I call her after every 3 months and then 6 months. That this is the protocol I'm maintaining for from the
They
day
may
I
not
practice.
notice it, but quite often it is expelled.
Yes. So
and acute bleeding, never put in an LNG IUD.
Yeah.
Never put it in. Along with hysteroscopy also never put it because it will get expelled. क्योंकि वो cervix इतना dilated रहता है. Maybe even endometrial biopsy also maybe you should not put it. After getting the report only you should do it.
It's a protocol which I have made for myself, and I have seen that with heavy periods there are very, very high chances of getting it expelled, and we have to tell the patient that if she has any kind of heavy bleeding, she must report to us anytime because there are chances of expulsion of these devices.
Okay, with that I come to the end of my presentation. Thank you so much for the patient listening, and I want all the panelists and all the people in the audience to record, to give us their inputs.
Dr.
Can I ask a question?
Okay.
I have not encountered that, but I just want to know if Mirena is expelled.
Yeah.
How do we reinsert it?
Expel means why can't you reinsert it later?
I mean, I just want to know because Mirena comes with a special insert. So I don't know how you reinsert Mirena. I mean, if at all it has been expelled.
Not expelled means not at the time of insertion. You'll have to put another one. You can't insert the one which has been expelled.
That's what I'm asking. Yes, Dr. Sandhya, madam. We look forward to you. Yes, madam.
Yes, sir. I have kept almost around 800, more than 800 Mirenas.
We're honored to have you here, madam.
Only because of cost. What I have done, our routine copper T insertion, cannula we take, I put it back into that and be cautious in putting it as if you are putting your routine properties. And I have been succeeded in more than 15 cases, particularly when poor patient, I don't reinsert the second one. And I try with these, and once it is properly placed sonologically, you confirm, and definitely they go in either amenorrhea or oligomenorrhea, and I'm very, very happy with it.
You know, this
Madam, I
Indian
want to ask you one question.
ILNG IUD was there, na?
Madam,
Sometimes
I
that
want
the
to
thread
ask
breaks out before inserting it. I have inserted even with a long artery forceps.
Okay.
Yes, sir, Natagiri of good there, good this, all that's not necessary. Take one artery forceps, it goes in easily, nothing happens. And it remains
Madam,
there.
I just want to ask a question from you, Sandhya madam. How often you give progesterone to this LNG IUG patients, you know?
Sometimes they bleed in
because they
spite of
come with
LNG IUD.
spotting. How often you have used in your practice?
As you said, I have made a protocol without, I usually use it in abnormal uterine bleedings, heavy menstrual bleedings, but once you find a thick endometrium, and many times from even the medical point of view also, we do for hysteroscopy, which is definitely giving us a very good information. And then after looking at the endometrium, we feel that it is comparatively benign. We don't suspect malignancy on hysteroscopy. I put Mirena at the same time.
But
And
madam, all my hysteroscopy
whenever there
patients
is
with Mirena, they're getting expelled. I've stopped doing that now.
Madam, expulsion rate is comparatively less with me somehow or other. In out of these 800, hardly 5 expelled
No,
out.
now I don't get expelled because I stopped putting it with hysteroscopy. I don't know whether it is hysteroscopy or whether it is bleeding that expelled it.
I think
Anyway.
Parag sir wants to make a comment.
Probably that
Yeah,
bleeding, madam.
Parag wants to say something. Dr.
Yeah,
Parag.
Anju, I'm responding to you. Now, if you have had LNG IUS in place and if the patient continues to have spotting or bleeding, you know, the first drug of choice which is recommended is tranexamic acid. And if it doesn't work, then it's prudent to give estrogen plus progesterone combination. Because see, LNG IUS will release only progesterone. So it doesn't make sense to keep on adding progesterone. So the endometrial will respond well to a combination of estrogen plus progesterone. So that is what is generally followed. We usually start with a higher dose, 50 microgram pill, and usually within 72 hours the bleeding stops. Then we continue it for.
How many months you give them these pills?
See, I will not continue it for, I mean, I will just continue it for that particular cycle, observe next couple of cycles. If needed, you can give it for 3 consecutive cycles also.
But Dr. Parag, always you do.
Most of the cases we are using this progesterone only. I don't know. That is what was recommended.
Even I do only that. I am not
so
tried
it's
OC
good
pills,
learning
but
from you.
Parag's method may be good. We have to try get inputs from everybody. That's very
Madam.
nice.
Yes, Andavan.
As and when there is a bleeding with Mirena, Parag, we first do sonography, whether it is in proper position.
Madam,
if it is even
sonography is
little,
very misleading, madam, because sonography में कभी-कभी mistake हो जाता है. I always do X-ray because they
लेकिन जब
say
displacement होता है ना, so when the displacement and you just reinsert, I mean, without taking it out, if you put it properly under sonography guidance, and again, if it is well placed, the bleeding stops of its own. That's what I have done. And
oh, that's one good
progesterone
thing.
and
You
estrogen.
just place
Madam,
it
lot of
properly, that
patients
can
have
stop the bleeding.
spotting because the dose is very low. This is my clinical observation. I have seen like at least in 20 to 25% cases I have seen spotting happening after Mirena.
But she has
That
given a
happens,
very
madam.
good clinical tip that you reinsert it properly and let the displacement be corrected. Because quite often we are putting it in patients with adenomyosis. इतना बड़ा uterus रहता है, उधर ऐसा घूम जाता है वो लोग. That होता है. Yes, Jyoti Jaiswal and Namita Grover want to say something. Neelam Agarwal also want to say something.
Check it sonologically whether it is on the buttock. The same time just after putting the
Okay.
LNG.
Yes, Jyoti, Namita and Neelam, please give your inputs.
Yeah, hello. Hi. Yeah, okay, Jyoti, go ahead.
Good evening, everyone. I am going with Dr. Parag in such cases where the
there is either displacement, it is difficult to replace them at that particular part, or sometime it can come down even to the cervical area, especially as Shobna madam said. It is in cases of adenomyosis. Recently, I had a case of adenomyosis where the patient's bleeding was not stopping at all with the help of the progesterone. She had one GnRH analog injection as well. She has Mirena put in since last 3 months. And in this particular cycle, when again I have said her to go and check for the endometrial thickening and all, why she is continuously bleeding even after one shot of GnRH and 3 months before Mirena, that we came out to know that Mirena is came down. In that particular case, Mirena was just about to expel. It has taken out. And then the addition of simply OCPs. OCPs in a little higher dose, like 1 BD I have given for 1 week, and OD
With 50
continued.
microgram, 30 microgram, or 20 microgram you have given BD?
30 microgram. The standard OCPs, madam, 30 microgram ethinyl estradiol. So I thought that because even she is not, the thing is not working with GnRH and progesterone, so maybe the atrophy can be a cause for the continuous bleeding. In such case, I have given simply 1 BD.
Very nice input, Jyoti. Thank you so much. And Namita and Neelam, one of you can start.
For 2 months, and she is
Yeah.
So
Yeah,
Okay,
I also
Neelam,
wanted
you
to
say
say
first, then
it's
Namita
almost
can.
yeah,
Neelam.
Shobna, actually, yeah, there are many times when the patient does not, at least she claims to have not improved even on Marina. So in those cases, we electively give 3 to 4 weeks of progesterone along with Marina. And in those 3 to 4 weeks,
How much
usually they
progesterone?
settle down.
So
we
Jyoti and
usually-
Parag are one side of the Antakshari, and Anju and Neelam are on the other side.
Yeah. So I
One is
usually give
progesterone,
them.
one is estrogen.
No. I usually give them progesterone CR 10 milligram daily.
1 BD.
CR
CR means 5 milligram है ना CR वाला tablet.
CR नहीं 5, 10, 15 तीनों है. मैं 10 milligrams वाला वन देती हूँ. 1 OD.
So
Because
practically it has got some estrogen in it.
Practically,
because norepinephrine in such
usually-
high doses will have some estrogenic effect.
Yes,
Okay.
yes.
Either
And-
you give progesterone or you give estrogen. So now, Namita,
I usually don't give estrogen because if mostly the patient is for
vomiting होते हैं क्या? I don't know. I've never tried. I don't know.
hyperplasia as well as in the age group after 40, I usually do not give high dose estrogen. Yeah.
No, but then these people are comfortable with it and they are vouching for it. So maybe there is some effect in younger patients at least.
Must be. Yeah, in younger
got-
patients.
Yes,
definitely,
Namita,
yeah.
Namita, you have to come.
Dr. Shobna, I just wanted to share one thing. I have put Mirena and I have experienced that if the uterocervical length is more than 9 centimeters, there are high chances of expulsion of Mirena.
Why?
Yeah.
Why?
And,
Because Mirena is above the cervix, no? Why should it get expelled?
It is there in the literature also. If the UCL
It's a paradox, na? Because itna lamba jana padta hai usko. Why should it get expelled faster?
No. You have that hub. You have that shoulder in the Mirena, which is of blue color, and you measure the UCL, and you get the approximate. You get the length of the uterocervical length, and then when you insert the Mirena, if it is more than 9 centimeters, it expels in most of the cases. My only query I wanted to address, I wanted to ask was that the doctor who said that she reinserts the expelled Mirena. Yeah, ma'am. So how do you sterilize the Mirena before reinsertion?
No? Sterilization comes as soon as you remove, you put in that sterilized inserter of another sterilize our copper T.
No. If the patient if the patient has expelled Mirena at home, she gets you the Mirena.
That cannot be reutilized. But when the patient comes with bleeding continuously with Mirena, I usually do sonography. I find that it is displaced. So if I can get it under the, I keep the cannulas in my formalin chamber sometimes, or in my autoclave, and I use the Mirena sleeve. So if it is displaced but has not totally come out, I put it under sonography guidance, that stump in my that Mirena inserter, and we can easily keep it in. The only thing that
So
the
you
cut thread
said
will
of
be
9
lost.
centimeter, be aware, and always put some copper tea inserted in a formalin. Formalin chamber to हमारा hospital से निकाल दिया है, because NABH doesn't allow it. But
Madam, agreed.
Thank you.
But
Thank you.
Madam,
particularly I have done it.
one inserter of new copper tea, if required, then
yeah,
it is
so what?
very
So what?
costly.
If you can always use another one, wasting, why waste 3,000, 4,000 rupees?
But
Yeah.
one who has expelled at home can never be reutilized.
Oh
Can
yes.
never
Okay.
be.
Now,
Yeah,
Dr. Kiran,
please.
somebody wanted to say something. Somebody had
Yes,
raised. Kiran,
yes,
say.
madam.
Yes,
Yes,
madam.
madam. Good evening.
Good evening, ma'am. Where are you from, madam?
I am from Kanpur, madam.
Kanpur. Okay.
आजकल जो उस तरह की भी इससे मिरेना नो एवरीबॉडी इज नॉट सपोज टू पुट मिरेना वेरी, अगर उसको इतना कॉन्फिडेंस नहीं है, आजकल कॉपर टी की तरह भी आ रहा है जिसमें लीवोनेजेस्ट्रॉल मिला हुआ आ रहा है. इट इज जस्ट लाइक कॉपर टी. Anyone can put it very easily, or it is Emerald के नाम से आ रहा है. It is cheaper also, costing only about 2,000 2,500. तो उसमें चूंकि मिरेना अगर आप डालो, उसका डालना थोड़ा सा ट्रिकी होता है. अगर एक बार आपका वो शोल्डर वो नहीं लॉक हुआ तो समटाइम्स इट इज बीइंग डिस्प्लेस्ड. लेकिन आजकल ये जो नए आ रहे हैं इमरेल के नाम से आ रहा है एक दो कंपनी, और इट इज जस्ट लाइक
sometimes they come without thread. मैंने बाइक के करना शुरू किया तो sometimes at the table you find there is no thread with it.
Shobana, can I make a comment on this?
Yes, Parag.
Yeah, okay. Now, what Dr. Kiran Sinha is saying is that, see, the Indian ones which are there, they are much thicker than Mirena. Now, when you, so Mirena generally, if you look at the insertion tube, it's very thin, generally not more than 3 millimeters. So usually, even without any manipulation, you can do it. The ones which are there, the Indian ones, we have used one product called Eloira, where it is little more than that, so about 4 millimeters or so. So one has to struggle to negotiate the cervical canal. That is it. But then if you prime the patient with a misoprostol at least 1 hour before the procedure, it is easy.
Have you tried that, Parag?
Yeah, we routinely give it. We routinely give it 1 hour before the procedure.
Okay, that's a new input.
No, we are
But
doing
all
it for
these
years.
adenomatic patients, they generally have soft cervix. Now, why you are starting another
give it
hysteroscopy का पहले देने का misoprostol. अभी मिरेना का भी पैसे पहले भी देने का.
Yeah, it is painless, Shobana. It is always. I mean, if the pain is less, then obviously the patient would be more comfortable and cooperative. No, buccally, गाल में रखते हैं.
अच्छा. Oh, okay.
We put in vagina. I mean, we put in per vagina.
That I have never done it, but I have put in so many. Emerald आता है, and that is very easy to put in. It is just like copper tea, madam.
Copper tea, correct.
Thread होता है,
Very
सस्ता भी
nice.
है, सस्ता भी है.
Okay, good.
हाँ, क्योंकि अगर एक बार आपका मिरेना डिस्टर्ब हो गया ना, उसका वो हो गया, तो then it is not easy, but it is very easy to put in. It is just like copper.
Okay.
A
Okay,
long
now
thread.
Dr. Jyoti wanted to say something more.
Yeah,
Jyoti, you want to say something
madam,
more?
there was one comment that, yes, madam. When there was a comment that the uterocervical length is, if it is more than 9 centimeter, the expulsion chances are more. The cause behind that is that sometime, especially in the adenomatic uterus, we actually do not reach up to the fundus when we are inserting Mirena if we are not looking at it with the ultrasound. So initially, I have some problems in such cases that it is only in the up to the middle of the segment or in the upper cervical canal only, and we think that because it is 8 centimeter or 7 centimeters, so we are well inside. But when we check through the ultrasound, then it was found that it is not up to the fundus, so the expulsion rates are more. So if
Sandhya madam's ultrasound guided Mirena will be very useful. So
Madam,
now,
ma'am,
Dr.
what
Girija,
I
you wanted to discuss a few cases after the panel discussion. We have many people who will continue to discuss. We will continue after Girija. But
So
Girija,
Girija
you
is
tell us your
I think she's
cases.
talking to a patient.
Acha, she's talking
Okay,
to a
I'll
patient.
just respond to Jyoti Jaiswal. Jyoti, generally, when the uterine volume is more than 150 ml, use of Mirena is generally not done because there are very high chances of expulsion, especially in
Absolutely
adenomatic
right.
uteri.
One,
So
one
it is
practical,
something which we
one
try and avoid.
yeah,
Yeah,
one
Neelam.
practical thing, yeah, because we usually get the poor patients because we are in the public sector. So what we have devised our own practice is that we give 1 month of oral progesterone, and if the patient responds to oral progestrogens, then after that we put in Marina. So they will have
What oral progestins do you give, Neelam?
same. Either Prevnuit
CR.
N1, yeah, CR 10 milligram once a day, because compliance is also good with one single dose daily, right? Progesterone CR or any other CR preparation, 10 milligram once a day. And once they have stopped bleeding, then after 2 to 3 weeks, we put in Marina and then slowly withdraw the progesterone.
Okay,
So
Anju is also doing that with Ocipil. You're doing it with norethistron.
Yeah, with
So, and then
norethistron.
in a non-bleeding state, you put in the
Marina, yeah, and that way you otherwise also you are sure that the progesterone has taken over, and mostly it will work because patients are poor. Marina is expensive, and with Emily, personal experience has not been good. I have used in 2 patients, but both the patients Emily didn't work.
Meeta also agrees that trial of progesterone should be done before that. No, Meeta, you want to say something more? Meeta? No, she's just put it in the chat box. Okay. So, yes, Jyoti, you want to say something?
Yeah, I agree with Neelam that though the Indian brands are less expensive, the expulsion rates are definitely higher. So in fact, I've actually try not to use them because then, in any case, you have to use another agent after that, either Marina or another of this. So it works out to be equally expensive.
Yes.
And they're pretty difficult to put in also, I think.
Yeah.
Difficulty in putting because what Parag gave that input that they have got 4 millimeter ka ye, and Marina has got only 3 millimeter. My God, how much knowledge you have got, yeah? Millimeter
I've
ka bhi baat karte hai.
I've given hundreds of lectures on Mirena in last 18 years.
तो ऐसा
We are
आता
using
है.
it for a long time.
Okay. मिलीमीटर का बात मैं पहली बार सुन रही हूँ कि इसमें 3 millimeter होता है, उसमें 4 millimeter होता है. Very nice input.
Used that Ilara only once and then I gave up.
Yes, Shubhada wants to say something. Shubhada?
Yeah. I used that Ilara only once and then I gave up because it was too thick and it was very difficult to put in.
Okay.
Yeah. Shobana, can I come in?
Yes.
Yeah. So actually, I was on mute. No, I agree with what Parag was also saying, and Jyoti, that the same experience. So that is the reason why I shifted back to Marina because expulsion rates are higher, even in my personal experience. And that is one. And there were 1 or 2 cases where we were able to replace the little dislodged Marina under hysteroscopy guidance. I mean, I cannot talk
You needed a
you
needed a hysteroscopy.
Yeah. Within office hysteroscopy, we are just a bit, when it
Tanvir
slipped
is
down
anyway there, na? You do it or Tanvir does it?
Tanvir, not me.
Okay.
So I just order and I watch, and it's a nice experience. But I cannot say much because it's only 1 or 2 cases, and we have to do more cases before we say it works. So,
No,
but it was a nice experience.
Okay.
Yeah.
So
thank you. Nice discussion.
Yeah, Shobana, just last comment. Sorry, I'm talking too much today.
No. We want people to talk. I designed my president's webinar series in such a way that I want only case discussions. वो पहला वाला lecture जो था ना और panel discussion था, that is only a stimulant for talking.
Okay. Now see, whenever this has been an experience with Eloira, I have not used any other. I mean, we are using primarily Mirena, sometimes Eloira. Now, what happens is because the diameter is little thick, when you are withdrawing it, sometimes the device also gets pulled out, and that could be the reason why it gets expelled much faster.
Okay,
And it
because the
doesn't happen
sheet
so.
is stuck to the thing.
Yes.
So when you're
yes.
pulling it out, along with that, even
it many a times dislodges the Eloera
तो
device
एक आर्टरी फोर्सेप डाल के अंदर डाल सकते हैं ना वो?
हाँ डाल सकते हैं, but then you don't realize it then. No? It
it
comes.
might rotate, like
Yeah,
madam said,
it
may
comes
be
later. It
dislodged.
comes later.
Okay, then. Anybody else wants to say something? Okay, then over to Pune.
Yes. Again, request for the form filling of pan-India
flashes.
study. Hot flashes form filling. So to the Pune Society also, we are requesting on pan-India.
And all of you, please come for IMSCON Calicut. If you want, I will display the video of the Calicut IMSCON. Do you want me to do that? 2 minutes?
Yeah.
Do it, Shobna.
Okay. वो क्लियर नीट का वीडियो दिखाता है, इसमें मेरा भी वीडियो दिखाती हूँ मैं. Where is my video gone? I don't know.
Mine not, madam.
Sorry? I can't see the video. How do you share screen on videos? Anyway, I can't share. See it.
No, Shobna, you can ask Paresh to share it on the Pune Society group. Anyway, Paresh is part of it. So
Okay,
you can
without
share
the
that.
video, all of you, please welcome to IMSCON Calicut, February 16, 17, 18. Calicut is a great place to visit, and there is hill station nearby, backwaters in Kannur and everything. If you are in a mood for enjoying, please come over. That's all I can say. Okay.
Before that, I invite everyone to Jaipur on 24th and 25th of September next month. And we are having a special excursion tour on 23rd, half day tour with Choki Rani for dinner. So all of you are invited to the Pink City in the pink weather. Welcome everyone. Parag is coming. I think a lot of people who are there are coming.
Oh, so we'll play Dandiya there now with everybody. Chal. Okay, over to Pune for your Thanksgiving or whatever.
Yes. I now take the opportunity to thank everyone for the webinar. First and most important, Dr. Shobana Mohandas, who is the brain behind this webinar. Thank you so much, madam, for such informative webinars, the chain of webinars, I should say. I also thank Dr. Neelam Agarwal and Dr. Neeta Singh, who were the guest of honor for today's webinar. Our chairperson, Dr. Parag Biniwale, thank you so much for taking time. Thank you to the speakers, Dr. Jyoti Unni and Dr. Girija Wagh, for such very detailed and informative talks today. Thank you to all the panelists for such an interactive panel discussion and very valuable inputs. Thank you, Shobana ma'am, for giving me this opportunity to be a part of this wonderful webinar. And last but not the least, thank you, Clarnet team and Shazia and Faraz for this coordination of this webinar, and all the delegates who have joined today to listen to all the academic fees today. So thank you all and have a very good evening. Thank you.
Okay,
Thank
say all
you.
good things
Thank
come
you.
to an end,
Bye.
and it was a very well coordinated webinar in Pune. Thank you all. Thank you so much.
And very good.
Thank you, Shobna and team.
Very good at it.
Yeah, thank you, Shobna. Thank you to the entire team.
Okay, then bye.
Hello,
Have
good
a
night.
great
Bye-bye.
day
Bye.
ahead and bye.